speak with my diaphragm. I've heard a lot of folks associating viral infections, and in particular chronic infections such as herpes virus infections, with the diagnosis of ME CFS. And I was wondering, have any studies looked specifically at herpes viral infections, or any viral infections really, as disease markers that could potentially be used for diagnosis?
There certainly are a number of studies that have looked at that particular possibility. I might suggest that Ron Glaser is probably one of the preeminent authorities in the world and has been doing research on this for a number of years. And certainly there might be some early proteins that might be particularly interesting that several papers have been published on that seem to be more evident in cases versus controls. And Martin Lerner has been an author of some of those papers with Ron Glaser. I think that the best studies in that area might be prospective, and that I think what you really want to do is get a large group of people and actually follow them over time. And if they do develop an infection like mono, and then to sort of get data on them prior to the infection, find out what happens with the infection, and then follow them over time. And a college-age population is perfect for that because students come to college, they often don't have exposure to the Epstein-Barr virus, and this would be a nice time to do that. And currently in Chicago, we have a study going on with Lurie Children's Hospital, Northwestern, Ben Katz, myself, and we are following about 6,000 students where we have both self-report and blood samples on individuals who are healthy, and we're going to follow them over time. So hopefully a couple years from now we'll have better information about the association with some of these viral titers and the illness.
Great, thank you.
Any other panelists? I have a question. Oh, please.
The research in ME CFS it used to be called chronic Epstein-Barr in the 80s, and so there were just lots and lots of studies looking at Epstein-Barr virus, different antigens associated with EBV. Later, HHV6 became a prominent player in the research, and so there are a lot of studies looking at that. One of the take-home messages is that you have to look longitudinally, that if you look at a cross-sectional sample, you don't see the same things that if you look over time with people's symptoms waxing and waning. And there are some limited studies showing that so do the herpes virus titers go up and down with that. More recently, there have been some treatment studies looking at treatment of herpes viruses, and people who have herpes viruses have had some success in improving and actually being well after certain treatments. So there's quite a large literature on herpes viruses.
Just very quickly to complement and to add on the herpes virus, one of the attractions of herpes virus, such as Epstein-Barr, HHV6, 7, etc., is their ability to become latent, and this could help explain fluctuations in symptoms in patients.
So my question, Dr. Kuhl, Dr. Steele, Dr. Nelson, is how confident are you that we're treating one disease?
You know, I don't think that everyone even agrees what it means to be one disease. I think that there could be different triggers, there could be different etiologic pathways that have a final, come together at some point in the cascade of events. So, for example, you could have an infection, your body responds in a certain way, and there's a cascade of immunological, neurological, endocrine events. You could have a different inciting factor that also brings you into that same cascade of events through a different pathway. So I don't think we're looking at one etiology, but I think we could be looking at some common pathophysiology between different etiologies. That's my take.
Great, thank you. Okay, we're going to go out to the audience.
Yeah, just to expand on that, certainly environmental toxins could be implicated with some individuals, particularly mold, and a number of people have gotten sick with exposures. I think it's very important to also differentiate what kicked off the illness, what predispositions might have occurred, or even genetic factors, but what's maintaining the illness now. Those might be a variety of different factors, and I think we just need to be thinking those types of terms.
Thank you. First
Yes,
speaker.
Dr. John Kaiser, San Francisco. I want to thank all the panelists for excellent presentations. My question is posed initially to Dr. Jason. So isn't it possible that the different diagnostic criteria that are being used to diagnose ME/CFS are identifying patients with different severity levels across the same disease spectrum? For instance, while all CFS patients are required to have debilitating fatigue for 6 months or greater, not due to any other medical cause, the presence of either severe sleep disturbance or profound post-exertional malaise may be more prevalent in patients with a more severe manifestation of the same disease process. And finally, one suggestion Dr. Jason made toward the end of his talk, which I completely agree with, is that CFS-ME might more properly be considered as this disease continuum, with CFS representing a more mild to moderate stage of the disease, and ME representing a more progressed, severe, and disabling stage of the condition. And really the treatment implications of not excluding patients with an early or more mild form of the disease process are profound, especially given the data that intervening earlier in the disease process has more positive outcomes.
Thank you. Any comments?
It's really, I would agree that severity is a critical issue, as well as having the necessary symptoms, for example, post-exertional malaise and memory and cognitive problems. There's a group that calls itself the 25% group, and I think what it refers to is that there's a lot of patients who are homebound or bedbound or housebound, and we often don't bring them into our studies because it's hard to get at them because they're not healthy enough to come to a laboratory-based area and give us their both physiological and other self-report data. So there's an incredibly important push now for us to understand the most severely affected, because if all our research is focusing on those who are healthier, who are able to get to our clinics and get to the settings where we do the research, then we're missing a large group of individuals. And I might mention, we've been able in our Chicago group to find a group of people who are homebound and in our large samples. And what's fascinating about it is when we looked at our data set of people that we've been able to reach, it was 25% of the sample. So again, it does suggest that there are some very severely affected individuals. We don't know a lot about them, and I think for us researchers, as well as clinicians, it's critically important for us to focus more of our research on that high-risk group, because they might be very different from the other groups that we've been studying over the years.
Great, thank you.
Suzanne Vernon, Scientific Director for the Solve ME/CFS Initiative. I'd like to make a point of clarification on one of the studies that Abigail cited, and that was the post-infection fatigue study from Australia. That included 3 different types of pathogens, so it wasn't limited to viruses. It was an RNA virus, a DNA virus, and a rickettsial agent. And the finding was that the post-infectious response was highly stereotyped and was associated with the severity of the acute infection rather than the agent itself.
Thank you.
Thank you.
Next speaker.
Marianne Fletcher. I'm from the Institute of Neuroimmune Medicine at Nova Southeastern University, and also a member of the Chronic Fatigue Syndrome Advisory Committee. My question is to Dr. Nelson. How much did this review cost and who paid the bill? And then secondly, was there seems to be a failure on the part of the committee to realize that exercise and psychosocial behavioral interventions are not nearly as expensive as trials of drugs.
Thank you.
And it should also be realized that NIH has actually never funded a clinical trial of a drug in ME/CFS.
Thank you. Dr. Nelson?
Thank you for your comments. I'm not sure what the exact price tag is. Our evidence reviews are a fairly modest, efficient form of research, and I'm sure we could find that for you. I'm not the PI. I'm one of the senior researchers on the team, so I can't tell you the exact price tag of the actual evidence review. And the funding was provided through the federal offices. I'm not sure how that flowed between the NIH and AHRQ. The Agency for Healthcare Research and Quality is the umbrella group that sponsors the evidence-based practice centers, but they're working in collaboration with the NIH. So I'll have to defer to the program officers of those programs as to how that actually worked.
Thank you. Next.
Hi, I'm Tina Nicholson. I'm a patient, and again, I wanted to just clarify what disease are we studying? Are we studying ME or CFS? Because in 2010, the CDC in the CMM course said CFS is not ME, and CFIDS is not ME. They're two separate, but now they're together. Now, if you're educating mainstream doctors about that, and then we have all these case studies, us patients who are going out there, at least I have an expert, the doctors they're confused. And basically, CFS has a lot of stigma, and there's a lot of diseases out there with stigma that names have been changed. And also, chronic fatigue is just one symptom. It's a multiple disease. Like we have the multi-symptom. I don't have fatigue. I have POTS. I have fibro. I have pain, and so on. So fatigue is just one symptom. It's really PME. So we really have to get down to it. I don't care what the name is. It just seems like you're merging two diseases together.
Thank you. Any comments?
I agree, it's a problem.
My name is Denise Lopez Mahano. I'm a parent of two young patients, not so young anymore. My younger son got sick at the age of 12. My older son got sick at the age of 14. This is an informally gathered list of people who got sick under the age of 18. There are 140 names here that I gathered very informally, very quickly, to bring to you today. I want you to be aware that there are patients who got sick very young. They were not addressed in the evidence review. I do not see where they're going to be addressed in this agenda. In excluding pediatric patients from the evidence review, most of the work on orthostatic intolerance was also excluded from the evidence review. Orthostatic intolerance is a very severe problem for a number of patients. How is that going to be addressed? It's like giving the panel an incomplete puzzle. Comments?
Thank you. Any comments in regards to that?
You want to comment? Sure. Or you have your thing on. Okay. You know, there's a lot of reasons for kind of an adult focus for this panel. But I must say that with understanding what's going on in youth, we gain an incredible vantage point that we don't often with adults. And let me tell you why. With adults, often you have people who have been sick for a long period of time. You also have people who have tried many different types of treatments. You have many types of complications. With youth, you have a chance to really study better because it's the initial manifestation of the illness. So I would argue that in terms of our priorities, we should be focusing on youth to really better understand this illness. Another kind of interesting issue is that when does onset of this illness occur? People keep talking about, maybe the late 30s, early 40s, but there's another peak, and that is in youth. We see, and again, I think there's 2 cycles that occur. So I think it's very important for us to be focusing on what you're saying for all types of kind of research reasons for us to basically get to understand this illness. Critically important, and it's a under-investigated area. Can I just kind of make a real quick comment, for the other speaker? I know you kind of mentioned that, you don't care about the term CFS or whether it's ME, but you're interested more in differentiating the illnesses. I would challenge that. The reason I say that is I think the term CFS has done considerable harm to many patients. And I think that we need to also understand not just kind of illness, but how people perceive illnesses. And clearly, there's research out there now that names do make a difference. It happened with HIV/AIDS. It happened also in this particular field. It happened with MS. There's many examples of how a name can begin to challenge people's attributions of what this illness is. So I do think...
Dr. Jason, I'd like to move on. Next.
May I make one brief comment?
There's other people in line, so please.
I'm talking about the same topic, so perhaps our comments can dovetail. Sounds like we need to spend a little more time on this topic. Hi, I'm Renee Taylor, and I was the PI of the study of adolescents. So it's basically post-infectious fatigue following mononucleosis infection. And I will be reviewing, the adolescents in our cohort were ages 13 to 18, so all under college age. I'll be reviewing those findings tomorrow. So if you'll look for my presentation, I know it wasn't a focus of the panel, but the panel was gracious enough to invite me, and I happen to be covering that.
So you have 1 more minute for your comment. You have 1 more minute for your comment.
It's over.
Okay, great. Anybody want to make a... I'm looking at time. Robert?
Yeah, I just briefly, with Denise's comment about not focusing on pediatrics, as a patient with the illness who has a daughter who's 36, 2 young boys who are 14, a grandson and a granddaughter, this is a huge concern for me. I think that there has to be more emphasis on the pediatric side of this. Thank you.
The last question will be the young lady with the laptop behind you.
Thank you. Dr. Carmen asked this morning, how confident are we that we are talking about one disease? Speak louder. Okay. The people answering that question talked about the various triggers of the disease, the presentation of the disease, and the heterogeneity of the disease that is being looked at. But the real elephant in the room, as Dr. Steele said today, is what disease are we talking about? Patients and experts have both endorsed the Canadian consensus criteria because it requires PEM. This morning we heard from Dr. Naku that there can be 163 different combinations of Fukuda. And we heard from Dr. Jason that as few as 25% of patients in Fukuda CFS studies have PEM. Because of the definitional issues and the confusion around the name, I think it's critically important that you ask the question differently. Do Oxford and CFS Fukuda CFS represent the same disease as MEICC and Canadian consensus criteria ME? And I think until you really come to grips with that question, you can't really answer the question that Dr. Carmen Green asked. So I would ask, what is the answer to that question? Do those 2 sets of definitions encompass the same group of patients? Thank you.
Thank you. Dr. McCool.
I think the syndrome is the same, the disease may be different. So that's one way of answering the question. Another possibility, and if you look at any disease, or most of the diseases that we know of, sometimes the same disease can have a huge spectrum. And some people, we take any disease, lupus, for example, they will have too many complications, there will be severe cases, and they'll need one type of treatment. and others will be pretty much mild cases. So to some extent, I think it's important that we have one syndrome, but we have different subgroups of that syndrome. And these subgroups could be either the mild cases and the more severe cases, or could be disease 1, disease 2, and disease 3. So I don't think we got to the bottom of the answer of your question, if everything is the same disease or not. But I think in any case, what is important that we stratify all individuals with the same syndrome, and then we can decide if they have different diseases or if they're just subgroups of the same. Don't know if this was... I think this complements a little bit of what Professor Jason said. I don't know if you would...
Dr. Jason, Dr.
Have any further...
Wilson, any comments? Okay.
Dr. Green, we have one more question from an attendee who's sitting down. Is that okay? Thank you.
I'm good with that.
Thank you. My name is Diane Lewis. I am retired. I'm a retired social worker. I've had the disease for 10 years. I've heard several of you state the finding that the statistics show that there's 2 to 4 females to each male that has this disease. And I would like to know if those 2 to 4 females were moved through the system faster, or if there's another reason why there's that broad range of women to that single male. Are the men just not showing up with the symptoms, or are we only targeting women for this disease so we can stigmatize them further? And the other thing was, I heard on socioeconomic status, I heard that this is people who do not have a high socioeconomic status. And yet it's my experience in the 10 years that I've been out here, winging it, that there are people with this disease that come from the medical background, educational background, the social work clinical background, scientific. These are people who are in the medical field working, and somehow they're the ones who have dual degrees, and they are highly active people before they got ill. Then they weren't, maybe they grew up and they had low socioeconomic status, but at this point in time, somebody with a dual degree is not somebody who just sits around, and this disease is not fitting for them. But, I accept that there are some people that do have a lower economic status. I had to fight for where I've gotten to, and I'm losing $40,000 a year just waiting.
Thank you for your comments. Anyone want to make a...
Yes, I can answer that. What you say is totally compatible with what we see in the population data. So that for many years, people believed that it was predominantly a women's disease because that's who was coming through the healthcare system. But now that we have done studies looking in the general population, we see that actually it appears to be a real biological fact that women have a much higher rate of chronic fatigue syndrome, ME, than men. So that appears to be real biologically, although the predominance of women is not as huge as we thought when we were just looking at clinic-based practices. Secondly, though, the issue of socioeconomic status, the rates, this illness affects people of all socioeconomic statuses. And again, early on, people believed that it was an illness of the higher SES folks. But now we know from larger population samples that we see a slight edge in people, a slightly higher rate, not a dramatically higher rate, in people with lower income, racial minorities. Lower income can be, when you're doing a prevalence study, it doesn't mean that they're more at risk. They could actually have a lower income because they're ill. So overall, we see it across all strata of the population. But there is definitely, there are some indications that there is somewhat greater risk among people with lower income.
I want to thank the speakers for their presentations. Please join me in thanking them and for a great discussion.